Professor Jones obtained his MBBS and BSc Medicine from Sydney University, a DPhil from Oxford University, and fellowships from the Royal College of Pathologists of Australasia and Australasian Association of Clinical Biochemists. He has been a staff specialist in chemical pathology at St. Vincent's Hospital since 1997. Professor Jones is active in the RCPA and AACB, serving as examiner for both organizations and chair or co-chair of committees on eGFR, urine albumin, common reference intervals, and the RCPA Quality Assurance Program. His special interest includes laboratory testing for cardiac disease, renal disease, and diabetes, as well as quality of lab results and uniform results reporting. So as you can see, he is a super expert in our topic today of renal function, and we're so excited to have him on board. So take it away, Professor.
Thank you very much, and thank you to Sam and Pauline and to the association for the opportunity to present to you. Pauline's indicated that if people want to type questions in, feel free to do so. I can't see them, so Pauline will look at them and see if to interrupt. Otherwise, at the end, I would hope we'll have some time for discussion about any of the matters that I've raised. The background to today's presentation is a talk that I gave at the Seoul 2022 IFCC meeting just a few months ago under the topic of estimating GFR, what's next? So talking about eGFR and what happens from that. What I've done is to add a few things before, during and after that talk aimed at this particular audience, and realise that there's really quite a bit to cover, so we'll get into it. These are my acknowledgements, which are different organisations that I've worked with at various times, including the College of Pathologists, Asia Pacific Federation, European Federation, IFCC, JCTLM, etc. And I just point out I don't have any conflicts of interest to declare, but also say that the opinions I express are my own and they're not on behalf of any of these organisations. What I would, however, stress is that a lot of the progress that's been made in the area of kidney disease testing in laboratory medicine has been as part of organisations that have worked with other organisations like renal organisations to achieve things. So you need to think outside your own lab to achieve the commonality and applying the standards that can be best practice for our patients. I'm just going to start with a few background slides. It will be well known to all of you, but it's just almost musing on the nature of the kidney. So this is a slide I use for medical students and ask them what are the functions of the kidney, and we've got electrolyte balance of common ones there. We've got water balance. We've got acid-base balance. We've got a number of specific endocrine functions like vitamin D, erythropoietin, the renin-angiotensin-aldosterone system. And it's known for getting rid of things that we don't want, like urea and creatinine, and obviously drugs. And all of this comes down to one word, that the kidney is involved with homeostasis, keeping our internal milieu in good shape. What that means is that our kidney is getting rid of the things we don't need, which to keep us in balance is that the amount we put in is the amount we get rid of in our urine after the other losses that might be in sweat or feces or others. So water, sodium, nitrogen, potassium, calcium, all of these are daily in balance where we get rid of what we don't want. We also need to reflect that the kidney is very, very good at this, that the homeostasis that it provides to us is very finely tuned. You know, it controls our sodium and water within a few percent over our lifetime. Within a day, the combination of hanging on to or getting rid of water, sodium, and all those other things that I've talked about is absolutely tightly controlled to maintain our bodily structure and allow us to function. So the kidney does an absolutely fantastic job for us in that way. Another way of thinking about that, and this was from a nephrologist, who said, when we measure things in urine, which is a whole sort of separate topic, it's what we're getting in there is the bit that the body doesn't want. And that can be a useful way to think about when we're measuring things in urine. What is renal failure? And I'll come back to the meaning of those words later. In essence, if we've got these functions, when the kidney isn't working, these all go wrong. And when that doesn't happen, we get failures of these things that we can see, like high potassium, too much water, we get an acidosis, we get low calcium and bone disease, we get anemia, high urea creatinine, we might get drug toxicity. And I can point out that, we won't go into a lot of these in any detail, but a lot of these are dependent on our laboratory tests to look for these effects of renal disease. So one way of detecting renal disease might be to look for these things, but that's not how we do it. The presence of every one of these and the severity of all these factors are all related to the fall in glomerular filtration rate, in GFR. And that's why we can use GFR for diagnosis and staging. And it doesn't matter what disease we're talking about, which renal damage we're talking about, whatever it is, they all lead to damage, to a fall in GFR, so we can use it for all of the diseases. The other advantage of GFR as a detecting kidney damage is that we can see it going down before these things start to happen. So it's an early warning, and that's one of the real key factors for the nephrology community, to try and identify kidney disease before it starts to have these effects on patients, with obviously the hope that we can intervene and stop the progression. Just very briefly, just to touch on some of the other main categories of renal failure. And again, a question I would ask a medical student, and they'd tell me there's acute and chronic, and they'd talk about pre-renal, renal, meaning intrinsic within the kidney, and post-renal. And just to go a bit further on the relationship between these, that really it's acute kidney injury, which divides into pre-renal, renal, and post-renal. Chronic really means intrinsic kidney damage. There's something actually wrong with the kidney. But then we also have this interplay between acute and chronic. These are not separate conditions. Acute can turn into chronic if it's not treated, and chronic kidney disease is a risk factor for having acute kidney injury. So a patient can have both at the same time, progressing from acute to chronic, or might have chronic with acute on top of it. So we need to be careful about not putting things too much just in those buckets. So let's go to the heart of the talk here. Estimating GFR, what's next? What I'm going to start with is talking about eGFR, the strengths, the good things that have come out of the whole eGFR process. I'll then talk about what I think are the issues that we need to face in the lab now and in the future for appropriate use of eGFR. We need to understand its limitations. I'll talk about the so-called race neutral equation that's been published last year. Talk a bit about formal GFR measurements, talk about the very important role of eGFR in drug dosing decisions, a bit about Cystatin C, and a bit about research into eGFR equations, hyperfiltration, and I'm just adding a little bit on acute kidney injury into the end. Okay, so let's go on to eGFR, the strengths. I think that this is a fabulous piece of advance in laboratory medicine. And this is a phrase that summarizes it to me as the most significant example of global clinical laboratory harmonization ever. It's an area where the labs and the research and the clinicians have worked together, and manufacturers have worked together to be able to deliver to patients and doctors an environment where kidney disease can be appropriately managed. And I'll just talk about some of the aspects of that in the first part of the talk here. So some of the aspects I'll talk about will be creatinine assay standardization, recommended eGFR equation, standardized interpretation, and new terminology. I did use the term renal failure earlier, but we should really never use that again. In Australia, we've got something like 40,000 doctors. They have been trained over 40 years, depending on how long they've been practicing. There's, I think, about 20, 25 medical schools in Australia, and we also have a lot of doctors who've trained at probably hundreds of medical schools overseas, and changing the way that we use language is really hard. But this has been a global practice to change this language from chronic renal failure and acute renal failure into chronic kidney disease and acute kidney injury. And the reason is to make it accessible to people, that people understand what their kidneys are, maybe, but they don't know what the word renal means. They understand the word disease, but when you talk about failure and say that someone's got renal failure, that suggests it doesn't work at all. So I've never seen this happen before, that language about a disease has been so effectively changed, and we should make sure that we use the right language as well. This is another aspect where, at least in some parts of the world, there has been amazing effects. If we go back to the year 2000, creatinine assays were not standardized. And then there was an active process led by the National Kidney Foundation in the United States to develop so-called IDMS, isotope dilution mass spectrometry traceability. And I can recall sitting in a room in 2008 where the major global manufacturers all said that they had delivered this. While we talk about IDMS traceability, I would put a different hat on and say what this means is traceability to JCTLM listed reference methods, materials, and measurement services. And what I've got there in that graph is a graph from last year from a sample, a patient sample, which was sent to 239 laboratories around Australia, 5 manufacturers, and those are all the results of the median result was 82 micromoles per litre. And the total country CV was 4%. So if you could send that sample, if your patient walked into any lab in the country, then that would be the kind of variation that you might expect lab from lab. And that is fit for purpose. You can monitor a patient without having to retest them at different locations. There is still room for improvement in Australia. We could go to enzymatic assays, which would be less prone to interference, and traceability can be improved. Now, that's what it is, if you like, today in Australia. And I realise that, I'm speaking in the Asia Pacific area, and I'm not sure how things are in those various areas. And I'll just refer back to some work that's now done some time ago. This was 2015, where we went to look and see all the package inserts, the instructions for use from all of the products that I could find at that stage and see what was there. If you're running a lab and you want to have IDMS traceable assays, you need to be able to find whether your assay is, and you go to the manufacturer's instructions for use. So this was 88 different creatinine assays from 20 countries, 5 continents. Because of my limitations, I'm limited to English language. There were 34 enzymatic assays, 53 Jaffe assays, and went through all of those there. And this is what we found back then. That of those, what was that, 88 assays, so 15, less than a quarter, could you read the IFU and it clearly stated the results were traceable to IDMS. There was some where it might have been, the calibrator was traceable, but if you were using a Jaffe assay, it may be that your assay wasn't. And then for well over half, those bottom groups, you really couldn't tell. And I raise this now in this environment because this is now 7 years ago. And I don't know how things are in the Asia Pacific now, whether people do have access to IDMS traceable assays, if they're available, whether laboratories are using them, and whether EQA in the Asia Pacific area is demonstrating that the assays are all traceable. Where this is perhaps particularly important now is that we live in the environment where everyone has their smartphone, and if they're getting a creatinine and they plug it in and do a calculation of an eGFR, they won't know if their assay is right or not. So I won't go further into this now, only to say I'd be very interested to hear feedback or questions on this later. And if people do have information on the current state of play of creatinine assays in the Asia Pacific region, that would be of great interest. This paper was written in 2012 and published in 2013. It's the KDIGO guidelines on chronic kidney disease. It's 163 pages. The main bits in the lab were in part 1, and most of what we need to know are in pages 5 to 7. One of the most striking things to me about this is, or there's two things. This document has changed the world in laboratory medicine and kidney disease, and it still remains the gold standard. And I'll just harken back to that last statement. It has not been updated, and as far as I'm aware, on nearly everything that is in there, and I'll touch on one area of controversy recently, this still provides the guidelines on what we should do in the lab. I note that in Australia, we wrote our guidelines in 2012, and we haven't changed them. And again, this is truly remarkable. In most areas of medicine, including laboratory medicine, things get updated with new information all the time, and we run hard to keep up and do things. Where we are now is that this document has been so influential that it is still, in my eyes, the gold standard. And if we're aware of this and talking about this with our clinicians, we're still on top of the game. That's not to say there hasn't been huge amounts of research and other things, but this is still the document. And it has been formally endorsed by the IFCC and the WASPAM Task Force on Chronic Kidney Disease. What's in here? A few things. First of all, equations, eGFR equations. And there are many, many, many equations for estimating GFR and for estimating creatinine clearance as well. The research is ongoing. I'll just make an aside. I did read on the AACC discussion group recently, someone said, oh no, there's another equation come out in research. And what I think there is, we have to be careful to separate out research from practice. Just because someone publishes a new equation doesn't mean we should use it, but rather we should consider it as national organisations or international organisations. What do we learn from it? What's the role? And see whether we might want to make a change. And still the guidance from 2013 from KDIGO was to recommend the CKD-EPI 2009 equation unless there is evidence of a better equation for your environment. And I'd probably even say an evidence that it will be better for your patients. And very particularly remembering whenever anyone publishes a new formula, it will always be best in that data set in which it's been built. Until you can see that it's been tested in other environments, you really can't believe any single publication on a formula. Where are we now? In Australia, we've had 100% uptake of the CKD-EPI equation in all laboratories, and all labs with adults are reporting eGFR. But I'll have to say I'm not sure where we are. I know that it's not uniform in the United States, and last I've looked into the Asia Pacific region, it's not uniform either to report eGFR and not necessarily uniform with equations. And again, I think this is an area where I would certainly be very interested to know what is happening in different countries in the Asia Pacific region. We were just speaking earlier, and I understand the latest guidelines in Malaysia are that these guidelines are recommended with the use, and I think it is with the CKD-EPI 2009 equation and the classifications as outlined. So, equations. Next, diagnosis and staging criteria. This comes straight from that KDIGO guideline, and it is the criteria for diagnosis. Do you have CKD or not? Does your patient have CKD or not? And if they do have CKD, what is the grading? And it's this matrix, sometimes called a heat map. We have the GFR classification down the left, and even better, it gives us some language. We can talk about to a patient. We could say you have, we call it G4, or we could say severely decreased GFR function. You could talk about moderately to severely decreased, and it has the numeric values across there. I quite like the version that a senior clinician once told me, that if we consider 100 mils per minute per 1.73 meters squared to be about a young normal, then someone who's got an eGFR of 50 has got about half of a young normal renal function. Someone who's got 20 has got about 20% of that function. And then across the right, we have the urine albumin subclassifications. And the importance of this is that it has been adopted globally. Every document that I have seen from individual countries has uniformly adopted this. So if somebody, when we talk about prevalence of CKD in different countries, we're using the same definitions. When we've got clinical trials, whether a patient is or is not in a trial, we're using the same definitions. When we're talking about a treatment regime on a patient using these definitions, we're talking the same thing. While it has classifications, it's based on risk prediction, what it means for the patient to have these. So green, which is not CKD, and in Australia that's about 97, 98% of the population is in that green box. That's the baseline, and they're not at increased risk of developing chronic kidney disease or in fact dying from vascular disease. As you go to yellow, to orange, to red, your increased risk of developing CKD or end-stage kidney disease and risk of dying from chronic from cardiovascular disease goes up in all of those. One of the really nicest things, however, and this goes right back to in Australia, our first association with Kidney Health Australia, was that they wanted the labs to do the same thing and match what they were teaching all the GPs, the general practitioners in Australia, so that the lab output fitted in with their education programs to general practitioners. And that has been maintained. So recall those colours there, the yellow, orange and red. And sorry, if you go to their website, what you'll find, and you can get it in printed form, your yellow clinical action plan, your orange clinical action plan, and your red clinical action plan, which shows what the local doctor should be doing in terms of what kind of testing to do, further testing, what kind of monitoring, what kind of treatments you might want to be starting, and particularly with red, whether you might want to refer that patient on to a nephrologist. So what we have there is linking the lab results, the eGFR and albumin creatinine ratio, directly with management in ways that then is bringing evidence-based practice to general practice. You will have noticed that I just stepped past a couple of slides there. I'll just go back. This is a study from Lancet in 2020, and it's part of their global burden of disease. And it's really just to make the point that chronic kidney disease is important. So the number of people in 2017 was almost 700 million people. I think the world population there was about 7 billion. So that's about 10% of the world has a diagnosis of CKD, and more than diabetes and all those others. CKD in 2007 resulted in 1.2 million deaths. And that's been projected to rise obviously quite dramatically over the next period of time. CKD ranking as the 12th leading cause of death out of the conditions that they follow, and more deaths than many other conditions that we spend a lot of time concerned about. In there, they do break down by various regions. On the left-hand graph is age standardized disability adjusted life years. Basically, just more of those is worse. And I've just highlighted the Asian areas, and we've got, first of all, some parts of Asia with very high levels of disability adjusted life years. They've described as Southeast and South Asia. Other parts at the lower end, so Australasia and high income Asia Pacific. But certainly we can see that chronic kidney disease is important in the Asia Pacific. Okay. If you like, those are the good things. Let's talk about what we need to do to deliver on those. Let's talk about eGFR. And one of the things in the lab, as we talk about it and offer advice on it and talk with clinicians, is to understand the limitations. And part of that is the uncertainty. While we produce a result, we might say it's 44 mils per minute per 1.73 meters squared or 72. It's basically a pretty rough and ready test. It's the best we've got. But the best we've got is plus or minus 30%. And that's the best case. So, we might get 80% of results within plus or minus 30% as the formal GFR measurement. So it's not brilliant, but it's as good as we've got. But it does mean that we can be wary about over-interpreting. Is 45 really different to 50? Probably not. One of the things behind this is that there's been huge work over the years to try and improve this. And I must admit, I was very hopeful that understanding, having better measures of body composition, particularly body muscularity, would really help. And the improvement has been minimal. And I'll come back to Cystatin C. So it's the best we've got, but it's certainly not perfect. The limitations, so that's with the best, that's within one assay with one creatinine, but there's limitations that we can understand and other things that we bring to that. So the inputs to eGFR are age, sex, we can measure most of those fairly well, and serum creatinine. So the results are affected by anything affecting creatinine concentration other than age and sex, that's in the patient, and anything affecting the creatinine measurement. So creatinine metabolism, clearly that will be affected. You'll have more of it produced if you're very muscular, less if you're emaciated or have muscle disease or amputation or paraplegia, quadriplegia. Changes in physiology. eGFR is not validated in pregnancy. It's obviously wrong in dialysis. Some drugs affect creatinine metabolism, like cimetidine. We know that well-cooked meat pushes creatinine up for a while. Dehydration will temporarily increase creatinine. And dealing with people with sex change creates some issues about reporting of eGFR. So these are patient-specific factors that we need to be aware of and may need consideration in interpreting an eGFR. Then there's the things about creatinine measurement, various interferences in the assays in our own labs. We need to recognise that there's no such thing as a perfect method, and we need to be aware of how the assay in our laboratory works. And be aware that we might be able to offer some advice on help with there. Bias and imprecision are both important. If we can get a CV less than 2%, then that is fantastic because it's low compared to biological variation. Probably going out to 3% isn't too bad, but we should be there. Bias is more likely to be bad with Jaffe assays than enzymatic, and bias creates even more problems with pediatrics because of the low concentrations that we're measuring. So these are things that we need to be aware of in the lab. So in the lab, we need to ensure our assay quality. We need to, when we have the opportunity, educate on the limitations and how we report it. For example, we shouldn't report eGFR in pregnancy if a patient's on dialysis, if there's other reasons to know that it might not be appropriate. Okay, let's just turn sideways for a moment. This is an area where I think it's an active question that we need to consider at our national level. I guess I've been aware of it for 12 or so months, and it's led to some changes that I think we need to consider. The so-called race neutral equation. And so we need to go into some background. So, as I said, the CKD-EPI equation was recommended for use in KDIGO in 2012. There's been a lot of talk, and I'll have to say, especially in the United States, about race being an inappropriate tool to make decisions on healthcare. And there's all sorts of reasons for this. And one of them is that it's actually not defined. So race is a very flexible concept, and defining whether someone is one race or another or a combination is incredibly difficult. And the current view seems to be it's actually a social rather than a biological factor. And if you go back, so the CKD-EPI equation had two versions, one for African Americans and one for non-African Americans. And depending on whether you put in African American or not, and the terminology commonly used was black and non-black, you would get a different answer. When you go back to that original paper, and most of it, the way that someone was classified as being black or non-black was a self-answered questionnaire. It was self-assessment. So even the criteria to say that someone was one race or another were not very tightly controlled. So what's happened in the awareness of this concept that race is not a good tool for identifying differences between people and may introduce biases in healthcare, that all that original data has been reanalyzed, leaving out that race factor. And they've come up with a new formula. It's called the CKD-EPI 2021 race neutral formula. And I'll talk a little bit about that in a second. And that's using all of the original data, irrespective of race. And the United States has gone rapidly to say that all labs in the United States should use that formula immediately. What I have not seen yet is any response outside the United States. That I haven't seen anything from KDIGO, and it may be there and I haven't seen it. In Australia, I know that informally talking with Kidney Health Australia, there has been no move to use it. And I'm not sure what's happening in other countries. In making that change, the National Kidney Foundation in the United States has provided guidance, and the April edition of Clinical Chemistry this year provides a lot of extra information for those who are interested. So the United States has advised it. That would affect all eGFR results in the United States. For those subjects being tested with the non-African American result, their values will go up. If an African American has been tested with the new race neutral equation compared to the previous one, their results will come down. So depending on where you start, there'll be a different. Now, many other countries also use CKD-EPI, and as far as I can see, usually without a race correction factor, and particularly not the African American, non-African American, or black, non-black. And so that was Australia. We've gone, we'll use CKD-EPI 2009 non-black version. And so what's the right response in other countries? First of all, what's the effect? So if this is using a data set of about 35,000 Australians that I happen to have, all ages, both sexes, and showing that if you went from race neutral 2009 equation and used the 2021, you went to the non-black and to the 2021 race neutral, as you can see, there's not a lot of difference, an average increase of about 5%. However, that doesn't happen to everybody. It's different depending on what your GFR is and how old you are. It has more effect on older subjects. So a person with a GFR of about 80 mils per minute, if they're 90 years of age, they will increase their GFR by 6 mils per minute, whereas a 20-year-old will only go up by 2. So it is affected a bit by age. That's in absolute terms that it pushes that up. Now, as we know that most people with CKD are older, and if you move up the GFR, measured GFR, you'll move people, you'll reclassify them on that if we keep using the same CKD definition. And this is again just using that Australian data to say that if, and I stress if, we were to change to the new race neutral formula in Australia, we would reduce the prevalence of GFR below 60, i.e. definition of CKD, and for people above 70, the prevalence of that level would fall from 34% to 27%. We would cure 7% of elderly Australians of chronic kidney disease. In ages 60 to 70, again, the prevalence would decrease with less effect at lower populations. So the decision to change the equation is not without some impact. And so the summary of effect, if a country is thinking of changing or a lab is thinking of changing, patients with non-African American equation will go up. Patients using the African American equation will go down. To be honest, the changes are modest relative to the overall uncertainty. We've talked about plus or minus 30%. So in an individual, you might say that's not important. The changes are age related. However, at the population level, you will move a whole lot of patients into different categories and be giving different levels of care. So my personal advice would be that any countries in awareness of this should consider this and act uniformly. For a person to go to one lab and get one equation and another lab and get a different equation doesn't make a lot of sense to me. And I'll stop there talking about that equation. Again, be very happy to talk about later, time permitting. I'm just going to touch now on various other relatively small bits, which I think are still live topics in what we need to know and may wish to think more about in the area of eGFR. So formal GFR measurements, typically not done in our routine laboratories. eGFR, it's very cheap, it's very fast, it's readily available in all labs, and it's very safe for patients. A formal GFR, maybe using a radio-labeled substance, is expensive. It's time-consuming, as you're going to collect samples over hours. It's done in specialised centres, and there's some risks to patients. You might have a line in for a period of time. You might be using radioactive substances. There are, however, some circumstances where a formal GFR might be needed. This is just a review article from suggesting possible indications. I'm not necessarily saying this is always true, but these are some circumstances where you might think, I really want to know the GFR, I want to do a formal measurement. And that might be extremes of body composition, either very high level of adiposity or very unusual level of muscularity. You might see that eGFR from creatinine and cystatin C are very different, and you want to know what's going on. Some drug dosing, and I think particularly cytotoxics, and particularly in pediatrics, where you've got a narrow dosing window, it's can be very useful to do a formal GFR. This group has suggested that in cirrhosis or kidney replacement therapy prior to someone donating a therapy, living kidney donors, in hyperfiltration assessment, there is a role for formal GFR measurement. So what's our role here? Just briefly, the techniques that you use for formal GFR, they typically radio-labeled. It's radio-labeled EDTA is used in our nuclear medicine department that does them. There are other methods. You measure the substance in either urine or plasma. You've got to get the timing of the samples right. There's a range of different equations. And what I'd be saying is that this really should be done by a centre that does enough of them to become skilled, because if you only do one or two, you don't get good at things. So having a centre, if you want to offer formal GFR measurements, look into it carefully and gain experience. Probably what we should do in the lab is at least be aware of where there are formal GFR services available. And if there is one of these scenarios where a better measurement is needed, then to be aware that that service either is or is not available and make an appropriate suggestion for referral if that's appropriate. Okay, drug dosing. To a certain extent, this is one of the, I think, forgotten areas of eGFR in terms of chronic kidney disease, and yet for people in the clinical pharmacology world, it is it's really front of mind. So adjusting drug doses with reduced kidney function is absolutely vital. This is a chance, as a survey some time ago, we went and asked doctors about the use of gentamicin, and one of them came back and said he doesn't use it very much because they were worried that they didn't want to be the person who gave their last dose of gentamicin that destroyed someone's kidneys. In other words, giving a drug to someone with not much kidney function can be very dangerous to the patient. So drug dosing is based on estimates or measurements of GFR, and it is and remains a contentious area. At times we've had competing articles in journals. I think it is coming together, but that's an area that we can be active of. But some of the key issues are which GFR estimation equation to use, and the issue of correction for body surface area, and I'll just talk a little bit about these. So what are our tools for GFR estimation in drug dosing? We can have formal GFR measurement if it's available and worthwhile. You can just use creatinine. You can do a measured creatinine clearance, 24-hour urine creatinines. You can use Cockcroft and Gault formula, commonly recommended in drug dosing information in package inserts. And note that's in mils per minute. We can use an eGFR formula, CKD-EPI or MDRD if labs are still using that, noting that's in mils per minute per 1.73 meters squared. Or we might use other markers, for example, cystatin C. So how do these two big ones, and this is where, really to me, the controversy has arisen. Do you use Cockcroft and Gault, or do you use CKD-EPI or MDRD? So, and for a long time, Cockcroft and Gault in mils per minute was recommended by experts in the drug field. And one of the rationales was that this is the method that was used in the studies which were done to identify the correct use of the drug. So how can you use a different formula goes one of the arguments, and that's a good argument. Unfortunately, a lot of the dated studies were done using creatinine assays, which are no longer in use, so it doesn't carry over so much. However, typically it gives lower doses in elderly people, and this is an area where pharmacologists and pharmacists have been very worried because they don't want to overdose an elderly person with poor renal function and cause them harm. One of the downsides is that if you produce a creatinine and you're going to do a Cockcroft and Galt, the doctor or physician or clinician needs to remember to do it. They need to go and do the calculation. By contrast with CKD-EPI, mils per minute, 1.73 metres squared, is not in the older studies. It's in fewer recommendations. It is, however, a better estimate of GFR. And one of the things that I like about it is it's right in front of the doctor. If you're looking at the creatinine, you've got the eGFR, you might go, oh, that GFR is 20. That patient's on digoxin. I need to lower that dose. It's right there. One of the really major studies here that I think is important here is, and it's now quite old, it's 2009, and it did use MDRD, but it had 5,500 subjects. They had a formal GFR, they had MDRD and Cockcroft and Galt, and they looked up what each of those would say about drug dosing for 15 different drugs where drugs are adjusted due to the GFR. MDRD was correct 78% of the time. Cockcroft and Galt was correct 73% of the time, using measured GFR as the gold standard. So certainly MDRD wasn't worse, and anywhere where you're just above or below a line, you're never going to be perfect, but it certainly wasn't worse. And they made the conclusion that the MDRD study equation can be used for pharmacokinetic studies and drug dosing, and as more accurate GFR estimation equations are developed, they should be used, presaging CKD-EPI. However, hidden in the small print, literally, in this paper was we adjusted the BSA adjusted values, mils per minute per 1.73 metres squared, for each individual by dividing by the individual's BSA, multiplying by 1.73, so that they were expressed in mils per minute. They removed the BSA normalisation. So unless we do that, we can't necessarily say that things apply. So body surface area, what is this all about? And if we're talking about with our clinical pharmacologists, we need to be across this. So what is it about? Basically, bigger people do have bigger kidneys and do have higher GFR. I think it is due to protein, that protein signals from the body signal to the growth of the kidney and lead to it being grown, lead to it growing larger. That's my best understanding. But smaller people do have smaller kidneys and have a lower GFR in mils per minute. There's less fluid going through the glomerulus in a smaller person. The aim of body surface area normalization is to remove that. And so otherwise, if we were diagnosing chronic kidney disease on mils per minute, small people would be diagnosed with CKD earlier and big people would be diagnosed later. It would have to drop smaller. So that's what the BSA normalization is about. However, these bigger people with bigger kidneys and higher GFR, because there's more fluid going through the glomerulus, they do lose more drug in the urine. Smaller people with smaller kidneys, lower GFR, they lose less drug in the urine and it may build up in that patient. So the amount of drug lost in the urine depends on mils per minute, not mils per minute per 1.73 metres squared. So dosing using eGFR is a risk of underdosing in large people and risk of overdosing in small people. Now, if a person is average size, around 70 kilos, then removing body surface area normalization doesn't make much difference and is not necessary. So what the guidelines have tended to suggest is use eGFR, normalize for body, remove that body surface area normalization if someone is an extreme of body size, either large or small. And down there are some suggestions, not guidelines yet, but just suggestions. Someone less than 50 or greater than 90 kilos or less than 150 or greater than 190 centimeters, it's worthwhile removing the body surface area normalization. Otherwise, given the uncertainty of it all, it may not be worthwhile. One area just I raised for your attention is some work by a group called EVQ. This is a piece of process in work at the moment. A guideline went out for public commentary in August this year, and the aim was to take drug dosing, in this case in cancer drugs, and put it in the context of the same decision points and the same device on for chronic kidney disease. Recommendation 1 says the same thing, but basically it's in recommendation 2. When the drug dose is dependent on kidney function, use the CKD epi equation. Just use that to guide drug dosing, and use the steps in KDIGO. So 1, 2, 3A, 3B, 4, and 5 for the drug dosing. Behind this is individual dosing information for, I think it's about 20 or 30 anti-cancer drugs, but using the same construction. So rather than having to think, oh, I use this for CKD definition and this for drug dosing, this group is trying to bring it all together under the same guidelines. So just stay tuned for this. It might be something that you can speak to your clinicians about if they are bringing something like this in. Just raising Cystatin C. We've been talking about it for many years now. It's, as you know, a small protein, freely filtered at the glomerulus, not produced related to muscle mass, so it gets around some of the issues of muscularity and creatinine. It's been widely evaluated as a marker for GFR, and standardized assays are available. The IFCC did a fantastic job producing an international standard. There are some formally recommended uses. So KDIGO recommends CKD stage 3A with a creatinine-based one to retest with eGFR cystatin C, and if that takes you out of 3A up to stage 2, you've cured them. They do not have CKD. If you've got any reason not to believe, so someone who's very muscular or very emaciated, a cystatin C GFR might be improved, but it is still very expensive. And in the big picture, the improvements over eGFR creatinine are still fairly modest at the population level. This is a busy slide. It's data from 2021, New England Journal of Medicine, with the revised race-neutral creatinine eGFR formula on the left in the original data set, and the same data assessed with eGFR cystatin C. Those two lines there, the green line is black subjects, the yellow lines are non-black. So on the left, we can see that those two lines, cystatin C removes a lot of the difference between black and non-black. But what we also see is that the P30, the percentage within plus or minus 30%, goes from creatinine 89% to cystatin C, 86% to cystatin C 89%. It's better, but it's not dramatically better. So the idea that it is going to miraculously improve our estimates of GFR is not true. In some patients, it will be better. If we can afford it, that's good, but there is still, it's not a game changer, in my opinion, for all of the problems with eGFR. Okay, I've mentioned this briefly before, research into new equations. They're still going on, as we've seen with just that last slide. There is still ongoing research for eGFR equations, and as we've seen, there's still room for improvement. Again, as I said before, any one study, it's the best that'll fit. Never believe an equation until you've seen it validated in training studies, and ideally in different places and with populations that best fit your environment. This is the difference, as I said before, between research and practice. Just because someone's published doesn't mean you have to bring it in. And my very strong feeling would be if you can have the same equation across a whole region or country, then a patient and a doctor gets the same information from different laboratories if patients move around. Hyperfiltration. This is under the heading of where we're going, what's new. Hyperfiltration is the increase in GFR above normal. There's no good definition for it. It occurs both in a pathological response in acute kidney injury, that in the ICU setting, patients can perfuse, can raise their GFR, and it's one of the early stages of diabetes-related chronic kidney disease. It found in a whole range of these conditions as listed there. In ICU, it's important for drug dosing, that if a patient is hyperfiltering, they're peeing out the drug you're giving. But there is no eGFR equation that works for hyperfiltration, and particularly not the CKD-EPI. So it's an area for future research. And if anyone has got a good equation, I would strongly recommend it. For the drug world, it can mean that therapeutic drug monitoring is important in this setting. I'm just going to give just a couple of slides on acute kidney injury. I know it's going slightly sideways, just to bring some thoughts, and then I'll be open for questions. This is the KDIGO definition of acute kidney injury, and in many ways, just like the CKD, chronic kidney disease guideline, the diagnosis and staging is very much based on what we do in our labs. It's based on serum creatinine. It's the change in serum creatinine over time, how much it changes, and gives you a diagnosis, and how much it changes gives you a staging. There's also urine volume criteria. That's not perhaps in our purview so much, but it's very based on serum creatinine, not eGFR, serum creatinine. So serum creatinine alone is playing an important role in AKI. Having said that, while lab testing is the earliest involvement of identifying and managing chronic kidney disease, I don't think that's true of acute kidney injury. So while we are involved in the definition, staging and monitoring, we can't solve it in the lab. Rather, acute kidney injury care starts on the ward. It's finding patients at high risk and starting the things that are involved in care of that patient before they develop AKI. And this is, again, the KDIGO guidelines. So you find the high-risk patient who's for a range of reasons, a range of criteria, and you start the care bundle ideally before they develop AKI. And we see here that monitoring serum creatinine and urine output is part of that. But you don't wait until they've got it before starting to do things about it. And then as they reach stage 1, then you bring in some more tests, more actions. As they reach stage 2 and stage 3, you're doing more to try and stop the progression of that disease. So the idea that lab testing is the first thing that you do with AKI, yes, you need to do it, but if you're thinking someone might have AKI, then a clinical response is needed. This is a study published in BMJ Open Quality in 2018, and looking at introducing care bundles in a large teaching hospital. It's a very nice paper. It's complex, and it shows a number of things. And what they've done is monitor the prevalence of AKI in that hospital as they introduce things. First of all, I love the way they've done a Levi-Jennings plot for the prevalence of AKI. So on the left is before they did anything, and we can see that the prevalence goes up and down with some control ranges. And then after they've brought in features, they see it go down. It's not down every month, but it comes down on average. And they've done a range of things. They've put an AKI app, they've got e-alerts, they've got pharmacy education, they've got learning sessions, they've got brought in the AKI bundle, they're doing fluid balance monitoring, they've got this safety huddle on the wards. In other words, it's not just the lab, they're doing everything around it. And one of the things is that to put an alert that when creatinine changes by a certain amount, they'll put an alert. But on the wards where they did not put these other things in place, just putting an alert didn't help. It didn't make a change. So just putting an alert to say, oh, your patient might have AKI after the fact is not enough. You've got to identify it early and put all of these factors into place to bring down the prevalence of AKI in hospital. And that's good for the patient and good for the hospital. Just one last thing. This is a report from the AACC on the acute kidney injury and the role of the laboratory, and it covers a lot of factors in there, but I'll just raise one, which is when we look at creatinine, how much change is important. Now, the definition of AKI is it goes up 50%. What this document is proposing is what it's calling the 20-20 rule, that a rise in creatinine of 20 micromoles per litre, or 0.2 milligrams per deciliter, pretty similar, or 20%, whichever is greater, is a significant change. It is a useful estimate of the reference change value. And it's easy to remember. You can teach your students creatinine up by 20% or 20 micromoles per litre. That patient has changed. As the authors point out, it was also developed in 2020, so that's when it was brought in. An assay with precision of 4% at 20% change has a 99% of that change being real. And it's also supported by some clinical data that if a patient changes by 20%, that's associated with increased mortality. So it might be that there will be a change in definitions coming soon. So this is my last conclusion slide, and we've covered an awful lot in today's talk. I guess this is called a masterclass, so hopefully that's appropriate. eGFR and associated factors, to me, have transformed kidney medicine, the way it's practiced around the world. We need to remember that eGFR equations are approximate only, and there are factors in the patient and in the measurement that are important. We need to know that this new formula, the CKD-EPI race-neutral formula, has been recommended in the United States, and we need in other countries to consider what we're doing. I think we should be cautious about rushing into this. We need to be aware that formal testing of eGFR is important, and if we can know how that works in our setting, that can be useful. Drug dosing decisions do need to be standardised, and they need to be made easy for the clinicians. It's a very complex area at the moment. Cystatin C may be useful, but it's certainly not an answer for everything. Hyperfiltration is not well addressed with current tools. If someone comes up with something good, I'd be very keen to learn. And also there's more to learn. Just to say that the Asia Pacific Federation is coming to Sydney in 2024, and I hope I can see you there. So with that, I will finish and stop presenting and see if there are any questions that people would like to ask.
Great. Thank you so much, Prof. Jones. Actually, we do have some questions already in the chat. Uh, and I've held off on asking them because I felt like you were getting to those questions. But maybe we can start from the top, which is what is your
Well, I can see
recommendations?
those now, so
Yeah.
I will go with
Ah,
those. So yes, we've got
all
what
right.
is your recommending for reporting eGFR in a pediatric population? So the first thing is that we should not use the adult one. Even a 16-year-old or a 15-year-old, you think they're nearly adult. What the eGFR equation will assume is that they're more muscular than an 18 or 20-year-old, and that's not true. So don't report even a close one. In Australia, we have no recommendations on reporting, and we just say to interpret against uh, reference intervals. I am aware, so as you're aware, there's a range of equations in pediatrics, and the Schwartz equation is one. And my understanding is, and I haven't checked on this recently, that the laboratory where Schwartz works has an estimated, so that's using patient height or length rather than weight, and using a normalized chart for how tall or long someone should be at a certain age does produce an eGFR. Whether that you could ask for the patient age or weight and to be submitted, then do the calculation. But my recommendation would be to make sure you talk about that with your pediatricians. I'll just continue with the questions. If someone wants to type or something in further on that question, please feel free. The next question, what is your point of view on, sorry, does someone want to ask that question now? Oh, look,
I
I'll
see
just
someone.
proceed with, sorry,
Yeah, I
carry
see
on.
someone with their hand up. So
Yes.
I've allowed you to unmute Dr. Anshuman. If you would like to, unmute yourself and ask your question, please go ahead. If not, Prof. Jones, please continue.
Okay, well, I will continue. So the question here is, what is your point of view regarding reporting eGFR for acute illness patient as they might be in a non-steady state? How about the role of eGFR in therapeutic drug monitoring? I'll address the first one first. And this has been controversial. And I know that some hospitals have said, do not report eGFR on inpatients because they might be having acute changes. I would take a different viewpoint, and for two reasons. Firstly, most patients are not in acute changes that For the majority of the patients, they will be there. The eGFR is still useful. And secondly, when you don't report an eGFR, what are you doing? You're saying, well, go on your serum creatinine. And then how do you interpret that? So what I think we need to be aware of is there's these two different questions. One is what is our best estimate of GFR now? And in acute changes, that's not good, but there's nothing better either. But the other is this patient changing acutely? And that's where serum creatinine is useful, and you should be looking at it to say it's going up or going down. And in that setting, I don't think there's anything better than saying it's changing, be aware of that, and be aware that the eGFR will be lagging behind where it is in the patient. But my personal preference would still be to report it rather than not to report it. And I guess that goes to that further question about the role of eGFR in therapeutic drug monitoring, that again, so many drugs are diagnosed, prescribed in hospital, that if you're saying here's not an eGFR, what are you saying? Well, go and calculate a Cockcroft and Gault. That is just as influenced by the acute change as the eGFR. So I can't see, and for most patients, the eGFR will still be better. So my feeling is it should be reported. I have a question there from K-Wing. Could you identify it's from K-Wing. Does point of care creatinine have a role in CKD detection or management in Asia Pacific? Absolutely. Having said that, and there is from Nova, there is a very nice point of care device. Having said that, it's not great. The sort of uncertainties, and forgive me, I'm doing this from memory, it might be plus or minus, it might have a CV of say 8 or 10%, rather than 3 or 4%. And it depends as long as you use it appropriately. If you were doing screening in a remote environment and that's the best you've got, and you can find a patient with a creatinine of 200, that's really useful. It might be also useful in a setting in like a radiology unit, if it's used for, say, rule out, okay, the GFR is greater than 90. The chance of that being less than 60 is very low. I'll use it for that decision. But monitoring a patient, particularly from a point of care, or that point of care to a lab one, you'll be way outside 20% quite often. So I think that point of care has a role, but it needs to be used carefully. But there are other point of cares like blood gas machines, iStats, which are very good, and they have a very useful role in emergency departments and other places. So with regards to hyperfiltration, there's a question there. How could you identify hyperfiltration patients when the max eGFR that labs report is 90? Answer, you can't. But even if you report it, you won't get an answer that's useful. That even if you report greater than 90, and with CKD epi, it's actually in the equation. As the creatinine gets low, it's what's called an inflection point, and it stops being an inverse relationship. So eGFR, even if you report greater than 90, you almost never see one greater than 125 or 130. It just doesn't work. So you can't, even if you report greater than 90, it won't solve the problem. A creatinine clearance gets up there, but it's not particularly reliable. So we don't have good measures of hyperfiltration with GFR estimations at the moment. And I guess it's all to do with the hyperbolic. As the GFR gets bigger, the creatinine levels out. It just doesn't change much as the GFR gets higher and higher, the so-called creatinine blind range. So not particularly useful. Okay, I need to just scroll down there. Okay. If labs use an assay where the IFU does not specify traceability to IDMS, could they run patient correlations with a traceable assay and, assuming excellent agreement and correlations, infer their lab is traceable to IDMS? My answer to this is yes. So when we talk about traceability of our results, that is by an unbroken chain of comparison back to appropriate references. And the question behind this is how well that's done. And so if you have samples which are commutable, and patient samples are best, and you swap those and they cover the appropriate range, and you check them appropriately, and you have the precision on those assays appropriately, this is what's called, in my mind, post-analytical correction. There is a lot of bias against this, but in my head, if it's done properly, this is an appropriate thing for a laboratory to do. Now, in an accreditation environment, you need to make sure that you have the data, that you verify it, and in doing that process and are enrolled in an EQA that can verify it, to me that does provide a traceability chain. But like all traceability chains, it depends on how well it's done. So my answer, yes, as long as you do it well. I see we have, is that another hand up there, or is that another question?
Yeah, it's the same hand up. I've also
Oh,
allowed
sorry.
to unmute. So
Oh,
I see they've been unmuted. Hello.
thank you.
Yes.
Hello. Thank you, madam.
Hello.
Hello. Thank you, sir, for this nice elaboration of this specific topic on eGFR. I am from India. My question is, some of the labs are also using MDRD formula, and some of the labs are also using CKD-EPI formula. And I have calculated in my laboratory by both of these formula, there is hardly any difference, 2 or 3. So my question is, which formula should I follow in my laboratory for calculation of eGFR if I measure creatinine by enzymatic method? Please share guide in this context.
Very
And
good
which
question.
would be the specific? Yeah.
Yes, very
Yes,
good
sir.
question. And it goes back initially to what I was saying, that um, uh, if you can, from my point of view, if you can provide a consistent information to your patients and doctors in the area where you work, then that is a desirable thing. So that if, for example, there is other hospitals around you or other laboratories, if you can meet with them and say, how about we all use the same equation, then that would be good. Even better if, whether it's one of the states of India, whichever state you're in, or even the country, can work together and say, let's use the same one. I agree with you. The difference is not high. But if there is, so the first thing I'd say to you is, if you know what other people in your area are doing and can meet with them and agree, then that's good. If I had to just choose one, I would go CKD Epi 2009, because that is in keeping with the KDIGO guidelines. And if somebody is, for example, using your creatinine and putting it into an app, that's the equation they're going to find more often, and then they will find your result matches them. It might not be very different, but if we can choose one, then I would follow the KDIGO guidelines.
Thank you, sir. But CKD EPI 2009 or 2021? According to national.
Yes, my strong view at this stage would be 2009, and in particular, not to change to 2021 unless you deal with, in many ways, it's an opportunity because of that to talk to your renal physicians and talk to other laboratories, and maybe through the Indian Professional Society, to say, what do we want to do with this? Do we want to change or not? But my own advice would be that change is unlikely to be beneficial in your area, so don't make another change that's not useful and might make your lab different to others. That's my personal opinion.
Thank you, sir. But most of the laboratory are using CKD EPI 2009 also and 21 also. They are mentioning on their test report form or report format. But I am not. I'm a little bit confused. You get my point, sir?
Yes, and as you'll see, mostly the difference is only 2 or 3. It might be 5 for an elderly person, it might be 5 or 6. to me, it's just making confusion. You're saying to the clinicians, if both are being reported, here's two results. They're not very different. We're taking an extra line of the report. I don't think it's helpful at all. I think choose one and stick with it. And I can see no reason at this stage to change. I think it would just be confusing. But that again is my opinion, that choose one. And if everyone around it, if every other lab around you did change, then I'd probably say just change, because the difference isn't a lot. And then you're consistent. A patient won't get two different results. I've got CKD at this lab and not at that lab.
Yeah, thank you, sir. Thank you very much for nice elaboration. So it needs harmonization in local area also.
I think so.
Yeah. Thank you, sir. Very good. Very good.
I see some more hands up.
Yes, I've also allowed unmuting for that. So please feel free to unmute yourself, Dr. Lopez.
অভিজিৎ not MD at CKD গ্রাম জোন্স যে আবিষ্কার করেছে তার একটা ওয়েবিনার এখন করলাম, কিন্তু 2009 সালে মত হচ্ছে এটা তোমার।
Hello.
So I'm from India. I'm Ajit Peter Lopez from India. I would like to know how the eGFR is calculated for children.
Okay, so there have been a range of formulas over time, and what I would do is direct you to the Schwartz equation. The actual paper in which, and I think it was, look, I must admit I've forgotten. We don't actually have pediatrics at our hospital, so I don't do it. But he published an equation which is using IDMS aligned creatinines, and there's two versions of the equation in that paper. There's one with, I think it includes urea and albumin, and another which is a simplified Schwartz, where the only inputs are, I think, length or height, sex, and serum creatinine. And that is the one which I understand is recommended for use in pediatrics. So Schwartz equation, the simplified version, would be my advice, but I will say that that's not an area of renal medicine I've kept up with recently because we don't have pediatrics. I apologize for that.
Thank you, sir. Thank you very much, sir. Thank you.
Is that one more question?
No, that was just a link from me.
Okay.
I found the link to the Schwartz equation. So
good.
just dropping that down.
Thank you.
Okay.
Any other questions that people would have?
While others are coming up with a question, just a quick comment or question. You mentioned meat can increase the creatinine, and the definition of AKI is 20. So if you eat a big piece of steak, can your creatinine go up by more than 20? Yeah.
Yes, it can. I mean, in the books that we grew up with, it was well-cooked meat or goulash. I know there was a study in the United Kingdom where hospital lunch was tested, and that was some luncheon meat type thing. And yes, it can go up by, in that setting of hitting the peak with a large load of well-cooked meat, can go up by 20 micromoles per litre. So certainly in an ideal world, monitoring chronic kidney disease, either fasting or certainly if somebody fasting or not near a meat meal is preferred. But yes, you could be wrongly diagnosing AKI if somebody, we might not be looking for AKI in people who are well enough to eat a large meat meal, but yes, it could do it.
There's a question from K. Wang. Can you comment on eGFR?
Yes, okay. So this is a very interesting question. So what we know is that with age in our populations, GFR falls. What we've got is the KDIGO guidelines, which specifically say that the definition of CKD does not change with age. And that was based on a particular study from and published in the Lancet, I think 2011, looking all available data sets showing that the meaning of having chronic kidney disease or eGFR less than 60 was just as important to a 70-year-old, someone over 60 years of age, as an under 60 years of age. Having said that, it is much more common to have an eGFR of 55 in an 80-year-old, and it's uncommon to have a GFR of 65 in a 17-year-old. So I would see this as still an area of ongoing work, and it's in some ways there's every so often there's a paper that comes out suggests a different way of thinking about this, but certainly the definition of CKD, which is KDIGO, does not include that. I guess one of the factors is in terms of prevalence of CKD is that if you have a population which is older, you will have more CKD. And so some of the population statistics on CKD are influenced by that. So my personal view would be that I think it is reasonable to treat people differently and have action thresholds different for age. But where we sit at the moment, from the renal world, the agreed renal world, is that KDIGO guidelines does not have age differences.
So I just want to point out that I've allowed mic for all participants. So if anytime you have a question you would like to ask, you can still unmute yourself. There's something popped up in the chat about post-transplant.
Okay, let me have a look there. Look, absolutely. So there is a classification of chronic kidney disease post-transplant, and it's an ideal tool. In some ways, particularly good because in that setting, you want to measure it frequently. And so you need a test that works in that setting. So after the transplant, particularly a single renal transplant, you'll get a new baseline, and then to follow the patient from that time becomes, a tool in trade. Interestingly, I have a friend who donated a kidney to his brother, and he showed me his creatinines, and they did exactly what you'd expect. That pre and post donation, his creatinine completely doubled. So as his renal function went down by half, taking out one kidney, his creatinine doubled. And then as that kidney expands, as it adapts to that new environment, the creatinine comes down a bit. But certainly eGFR as a tool post-transplant is entirely appropriate. Perhaps if I just make one further comment on that, the doctors who look after transplant tend to be transplant doctors and renal and specialists. So it tends to be an area where they go about their business and they don't perhaps need to speak to us so often. In the area of CKD, because CKD is so widespread, the advice to general practitioners and primary care physicians is where we're perhaps more involved in offering advice. For us to be telling specialist transplant physicians about how they use eGFR, that's their area of expertise, and I certainly won't be trying to tell them what to do. Okay, any other?
Bill wants to close, but a very quick question. I mean, the recommendation not to use the CKD epi equation in children. I don't know how closely that's followed in Australia. Are you aware if it's not used in pediatric settings?
I would hope it shouldn't be. When we did a survey of which hospitals were using CKD epi, and this is some time ago, only one hospital said they weren't using it, and that was the Children's Hospital at Westmead, because they don't have any adults. But it's just wrong in kids. So I would certainly hope, but we haven't done a survey on it, but I would certainly hope that it is not being, the CKD epi equation should not be used in people under the age of 18.
That's useful to know. At Royal Perth Hospital, we don't have children either, so but I would certainly like to look around in Perth how it's used or not used. Thanks for that. And thanks for that excellent talk, Brian. That is fantastic. I'm sure the audience there loved it. Thank you very much. I'll let Berlin take over, close this whenever she sees fit.
Great. I see someone who has unmuted themselves, Dr. Umi Aziz. Did you have a question that you wanted to raise? No, okay. In that case, thank you so much. And we already kept Professor Jones over time. So if you have further questions, please, I think you can just email and we'll still try to address them if possible. Thank you so much again for your time. Thank you to Professor Jones for his time and your support for this excellent lecture. Just some housekeeping. So we would love to have your feedback. You should get the feedback form in your email, and if you fill in the feedback form, then we will send you your certificate of attendance. And our next month's lecture is actually going to be a Q&A on lab quality by Professor Badrick and Dr. Lo Ziping from Singapore. And this is going to be an open forum, so please come prepared with all your questions. Ask them all the tough questions that you have on laboratory quality. and just like you've done so well for Professor Jones. So thank you so much. And thanks again, Professor Jones, for your time today.
Thank you very much. Great pleasure.
Thank you very much, Prof. Jones.
Thank you.
Thank you, everyone. I'll end the meeting for everybody now. So thanks again and see you next month.